Um, Louis Ptacek, MD. Again, my little crib notes. Dr. Ptacek is a leader in the field of human neurogenetics. Years ago, his group began the study and identification of channelopathies. And over the past decade, his work has resulted in the identification and characterization of numerous genes causing diseases like periodic paralysis. Welcome, Dr. Ptacek.
Thank you, Jeff. And let me echo the comments of some of the other speakers. It's such a pleasure to be here and to be sharing our experiences together and learning, hopefully, from one another. Well, I'm going to give a more historical perspective about the field of the channelopathies and also put it in the context of many other neurologic diseases that I have interest in. As a resident, oh, and by the way, I guess the book says I'm from Utah. I was in Utah for a long time, but I've been in San Francisco for 15 years, so some things move slowly, like updating of the files of the PPA, I'm afraid. So that's okay, that's okay. No, but I had many good years in Utah where all of this work began. And as a resident there, I was interested in migraine and epilepsy as a neurology resident, and all the other disorders as I learned about them on this list, because they're episodic. And so for the genetic forms of these disorders, it's pretty interesting to think about this. Some of you are walking around your entire life, and even before you could walk, in your DNA with a mutation that causes hyperkalemic periodic paralysis, paramyotonia congenita, Anderson-Tawil syndrome, or whatever. And yet, much of the time, many of you do very well and are, indistinguishable from people without periodic paralysis. And so the gene is there, the mutation is there, and the propensity for the disease is there, but it only shows itself occasionally, and it's usually when your genetics interact with some environmental stimulus. And it could be vigorous exercise followed by rest, it could be eating lots of potassium if you have hyper-KPP. It could be because of a large carbohydrate meal if you have hypo-KPP. But I find this remarkably fascinating that the system, our bodies, can compensate for these mutations and do pretty well most of the time. But you wouldn't have a disorder and you wouldn't have seen a neurologist if it didn't raise its head from time to time, as it does with some of you, to cause you to be weak or paralyzed. So the list of episodic and electrical disorders of the nervous system is really quite long. Periodic paralysis is really a very important one in the history of this field. It really opened up this whole field. But migraine and epilepsy are there. Cardiac arrhythmias are on the list. Episodic movement disorders like episodic ataxia or the paroxysmal dyskinesias are similar. They're episodes of or attacks of headache, seizure, abnormal movements, or paralysis, depending on which disease we're talking about, in people who often are otherwise completely normal between attacks. And so while these disorders, to a clinician and to many lay people too, you say, well, epilepsy and migraine are completely different, or periodic paralysis and cardiac arrhythmia are completely different. There are many things that led me to believe that they were actually quite similar in other ways. Well, they're all episodic. I've selected them on that basis. But it's interesting that the precipitating factors, so if someone has a mutation that predisposes them to some episodic phenomenon, let's say periodic paralysis, it's uniformly the case that stress of any kind can lower the threshold for having an attack. Being tired can lower the threshold. Certain dietary factors, high potassium, low potassium, and in some of these disorders, not so much the periodic paralyses, alcohol and coffee can precipitate attacks. And then the drugs that we use for the cardiac arrhythmias can be very helpful for the myotonia in patients with paramyotonia congenita or hyperkalemic periodic paralysis. Anticonvulsants like Tegretol are like a silver bullet. It essentially cures the episodic movement disorder, paroxysmal kinesiogenic dyskinesia. And then there are also all these interesting natural history similarities. So most of these disorders come on during childhood, worsen during adolescence and young adult life, and often will get better and sometimes go completely away in adulthood. And so that's something we don't understand. But these are some of the things that led me to believe that there might be some underlying similarities. And I just wanted to highlight stress because, again, we don't understand what it is about stress, but stress certainly, for any of these episodic disorders, lowers the threshold for going from being fine and not having any trouble into an attack of paralysis or headache or seizure, whatever the disease may be. Well, so this is where it all began for me, and this is a picture of 100 people who I collected from a large Utah kindred beginning when I was a resident. This is the family, these are descendants and some of the same people from a family that was reported by Frank Tyler in 1951 in the Journal of Clinical Investigation. Dr. Tyler reported this family. This is a more recent iteration of the family. And this was the first report of hyperkalemic periodic paralysis. And as you can see, it's a highly genetic, highly penetrant disorder. The circles are women and girls, the squares are men and boys, and the filled in circles and squares represent people who are affected by hyperkalemic periodic paralysis. And so even as a resident, completely green and wet behind the ears, after I had seen 40 affected people in this family, I was immediately one of the world's experts because I had seen more periodic paralysis in this one family than all but really probably Ken Ricker in Germany at the time and Birch Griggs at Rochester and a few others. So this large Utah family was my introduction to human genetics and to hyperkalemic periodic paralysis. Now, different from Dr. Weber and Professor Cannon, I still call these disorders hyper-KPP and hypo-KPP, and I'll make a plea again. Hyper-KPP, people say hyper what? These disorders are all named for the response that patients have when they're administered potassium or when their potassium level drops as a result of glucose and insulin. And so rather than calling them hyper and hypo-PP, I call them hyper-KPP and hypo-KPP because the K is really important in terms of making the diagnosis. Now, as you've heard, the genes that can cause these disorders can be K channels or Ca channels, calcium channels, or sodium channels, and for the non-dystrophic myotonias, even chloride channels. But these are some of the phenotypes that we recognize, and it depends on whether you're a lumper or a splitter. Some people have tried to break them down even further, and there are the paramyotonia congenita is a cold-sensitive phenotype, and then potassium aggravated myotonia and myotonia congenita are disorders where we see myotonia without periodic paralysis. So a couple of caveats with regard to the K in hyper-KPP and hypo-KPP. The K doesn't have to be high or low to make the diagnosis. Many patients have normal potassium during their attacks. And really what the K denotes is that in hyper-KPP, we can precipitate attacks in you, if you have this disorder, by giving you a lot of potassium. Even if your serum potassium level itself does not go up, we can precipitate the attacks. And these patients sometimes will have high potassium levels during attacks, but often they won't. And so this led people to call something normokalemic periodic paralysis. It's not. It's hyperkalemic periodic paralysis in which the serum potassium is normal during an attack that you happen to measure it. Another kind of interesting problem is that somebody raised the question of temperature earlier. How many of you don't have periodic paralysis? I don't want to leave you guys out, okay? Okay, for these people that don't have periodic paralysis, how many of you, your muscles don't feel very good, or you might even feel weak if your muscles get really cold? Okay, so one of the problems with the diagnosis of paramyotonia congenita, which is a temperature-sensitive phenotype, is that they say, patients say, oh yeah, no, I'm worse when it's cold outside. Well, so am I, and I don't have periodic paralysis. So paramyotonia congenita requires a quantitative test that we can do in the laboratory with an EMG and nerve conduction studies with cooling of a muscle. And so this is a mistake that's frequently made, because myotonia congenita patients, for example, have myotonia but no periodic paralysis. But they're often called paramyotonia because they say, oh yeah, my muscles are worse when they're cold. So that's different. A subjective feeling that my muscles don't work as well when they're cold doesn't mean it's paramyotonia congenita. So now, for all of these disorders that I began with, all of these episodic disorders, some of them we can measure stuff in patients, and many of you have had these kinds of tests. If you have paramyotonia congenita, myotonia congenita, or hyperkalemic periodic paralysis, most patients with hyperkalemic have myotonia, which we can measure in muscle by putting a needle in the muscle. Now, if you're in a paralytic attack and you're completely flaccidly paralyzed, your muscle will have no electrical activity. It'll be completely electrically silent. And so that's actually interesting and important data to have in terms of making the diagnosis, but that doesn't mean that the patient doesn't have myotonia when they're not fully paralyzed. But in the case of cardiac arrhythmias, like this example of ventricular tachycardia, you see that there's a similar but somewhat different, recurrent depolarization, abnormal depolarization of cardiac muscle that leads to very fast heart rates that can actually be life-threatening. And then in the case of an electrographic seizure, as shown here, someone who underwent an EEG during a seizure, we also see waves in the brain that are repetitive, highly organized. They're not chaotic, they're highly organized waves, but very abnormal. And so while the physiology of muscle and heart and brain are all somewhat different, there are also some similarities. And the similarities of these abnormal tracings that I'm showing here are yet another thing that suggests that there might be some similarities in terms of hyperexcitability among these tissues. Now, another interesting part about many hypokalemic periodic paralysis never has myotonia, but for hyper-KPP, paramyotonia congenita, and for example, another interesting thing about these disorders is that there are elements of both hyperexcitability, the myotonia and the cramping feeling that such patients talk about, versus complete inexcitability in the case of a flaccid paralysis. And these things are linked via the physiology of skeletal muscle. And Steve and Frank talked a little bit about this, but the transition from hyperexcitability into inexcitability is represented clinically in the movement from a patient who's experiencing myotonia who then goes into paralysis. Well, this is where it all began. This was a paper in 1991, and this is the first channelopathy. This is a report of the voltage-gated sodium channel from skeletal muscle that we published in November of 1991, so coming up on 26 years now. So this is where the whole channelopathy field began. And there was a subsequent paper shortly thereafter by a collaborative group of Eric Hoffman, Bob Brown, and Jim Casella. And then a lot of action began to happen, and things started to unravel rather quickly. But an interesting point buried in the discussion of this paper that I'd like to have you guys think about, not relevant to the periodic paralyses themselves, but we suggested that the periodic paralyses actually might represent a useful model or paradigm for studying other electrical disorders where electrical signaling was abnormal, and including epilepsy, peripheral nerve disorders, cardiac arrhythmias, for example. And so, based on the clinical similarities, based on the fact that this is an ion channel, and based on the fact that there are many ion channels, different ones expressed in heart, muscle, brain, peripheral nerve, we suggested that these kinds of channels, relatives of these channels, evolutionary relatives of these channels might underlie familial causes of cardiac dysrhythmias, epilepsy, and even some forms of headache. And so we began marching through many families with these disorders, collecting DNA and doing genetic mapping and then cloning to identify a number of genes that and lots of mutations that cause all of these disorders. And they represent channels that have selectivity for many different ions, including sodium, calcium, chloride, and these are both potassium channels. Now, taken together, I would say that these all together, in patients who are really rigorously evaluated by an expert in the field, that probably 80% of all patients have mutations in one of these genes if they have bona fide and classical disease. So the reports that you'll sometimes read that 80% of patients are undiagnosed, that or 80% of patients with familial periodic paralysis don't have mutations. They're just wrong. There are lots of patients who have some kind of muscle weakness problem that isn't periodic paralysis, and those often lead some, the poor quality of diagnosis on the front end often leads some to say that the mutation rate is much lower than it actually is. Now, Anderson-Tawil syndrome, in fact, this gene that we reported in 2001, KCNJ2, actually only represents about 2/3 of the families. So we're actively looking for other Anderson-Tawil syndrome genes that explain the other third. And then thyrotoxic hypokalemic periodic paralysis it's a periodic paralysis, but it's quite different in as much as these patients have, at least some of them that we've characterized, have mutations in ion channels, in an ion channel, KCNJ18, which predisposes them to have episodic weakness, but it only occurs under the conditions of a high thyroid. So if this is different in that if a patient comes to the clinic or the emergency room paralyzed and their thyroid function tests are very high and they meet some other criteria, and we say, oh, they have thyrotoxic hypokalemic periodic paralysis, these patients, that's too bad. They have periodic paralysis. The good news is that once you treat their hyperthyroidism, their muscle disease goes completely away. And so this tends not to be as long-standing a problem because once it's diagnosed, you can treat the thyroid disease and then the muscle disease disappears. So these are cartoons like ones you've seen already from others of potassium, sodium, and calcium channels. There are about 80 potassium channel genes in your genome, 10 sodium channel and 10 calcium channel for the alpha subunits. So 100 genes, and these are all evolutionarily related, unless you're Sarah Palin, in which case they are not. But the progenitor potassium channel shown here has 6 transmembrane segments, and then as you noticed previously today and perhaps in previous conferences with similar pictures, there are 4 of these units all sewn together in one protein in the case of a sodium channel or calcium channel. And so in our cells, we know that these potassium channel subunits, that 4 of them have to come together to form a functional channel in your cell membrane that will allow potassium to come into the cell. In the case of sodium and calcium channels, during evolution, there's been a duplication of some progenitor genes, and then a reduplication, so that all 4 of these are present in a single gene, in a single messenger RNA, and that are translated as a single protein that has essentially 4 of the subunits all ready together as one protein. And so it's thought that only a single copy of this protein is necessary to form an alpha subunit of a sodium channel or a calcium channel, and that 4 of them have to come together in the case of a potassium channel. But they're all related, and if you line up the sequences of all of these 100 genes in your genome, there are many similarities across all of these different channels. But then there are also differences, and different ones are expressed in heart or in different brain regions or in your skeletal muscle. And where, if you have a mutation in one of these genes that causes trouble, what kind of symptoms you have depends on where the gene is expressed. And for most of these genes that I've been talking about, they're almost exclusively, if not exclusively, expressed in skeletal muscle. The ATS potassium channel is quite unique among the channelopathies in the muscle world, in that it's a widely expressed gene, and patients with ATS don't only have muscle disease, they also have cardiac arrhythmias. They can have developmental problems in the distal limbs and craniofacial structures, and they even have some neurocognitive symptoms because it's highly expressed in the brain. And so one of the benefits of having studied many, many families, hundreds of families with periodic paralysis and non-dystrophic myotonia, is that after cloning all of these genes, we're able to look at all the clinical data and put it together with all the genetic data. And I don't mean for you to be able to read this, but our way of thinking about these diseases, organizing them, and the diagnostic workup to make the correct diagnosis has changed as a result of growing knowledge. And this paper, first authored by Tim Miller, who was a fellow at UCSF, lays out a scheme for approaching patients with periodic paralysis and what decision points, what tests have to be done, what questions have to be asked to start to sort through all of the possibilities. Hyper KPP, hypo KPP, ATS, myotonia congenita, et cetera, et cetera. So I put in a couple extra slides to emphasize some of the beautiful points that Dr. Cannon made earlier. In the muscle cell, on the left side here is the intracellular, inside the cell. And he mentioned that normally at rest, the inside of the muscle cell is negatively charged and the outside is positively charged. And that's because there are these pumps that both he and Dr. Weber mentioned that are separating, that are pumping sodium one way and potassium another, and there are many different kinds of pumps and co-transporters. But the idea is that at rest, the inside of the muscle is negative. Now normally, this allows our muscles to do something that's really important for our survival, and nerves too, for that matter. When sodium, when sodium goes into the cell, it can depolarize the inside of the cell. It can depolarize the membrane, and that leads to the firing or to the contraction, the cascade of events and changes in calcium that lead to contraction of muscle. Now, in neurons, calcium moving into the cell is also important, although less so in the case of muscle. Now, once we've fired our muscles, we also have potassium channels and chloride channels, which are having the opposite effect. Notice that with the inside of the membrane being negative, that if you let positive ions in from the outside, sodium or calcium, let's just focus on sodium, that will make the inside of the membrane less negative, more positive. Now, to get back to rest, now we have to get positive charges out of the cell or more negative charges in, and that's done by these channels, these kinds of channels. Potassium channels taking positive charges outside of the cell because potassium's high inside and low outside. Sodium is high outside and low inside. And you can have the same effect by moving negatively charged chloride ions into the cell. And in the case of the periodic paralyses in general, and I think this is going to hold up for the ion channel epilepsies and long QT syndrome and all of the others as well, three different things can lead to the same sort of end problem, which is too much depolarization, too many positive charges inside the membrane. That can result from the sodium channels being leaky, as Dr. Cannon was discussing, so too much positive charge going in, or with problems in potassium channels, too few potassium ions, positive charges going out, or too few negatively charged chloride channels going in. All three of these effects would be similar in that they would lead to the inside of the membrane not getting back to being as negative as it normally would be. And so there was, quickly after cloning all of these genes, and then we and others, Steve and many others, doing physiology on the mutant and wild type channels, it became clear that it sort of made sense. And the calcium channel, as Dr. Cannon mentioned, was much more complicated and not well understood until his beautiful work in the early 2000s that helped us to understand the kind of leak current that is contributing to those phenotypes. So there are lots of similarities. They're different channels, but there are similarities in terms of the final common pathway to hyperexcitability and inexcitability in all of these disorders. And so I'd like to come back to this idea that people are normal much of the time despite having the mutation all of the time. And Walter Cannon was a scientist who, in the late 19th century, introduced this term homeostasis, which is the process by which systems, complex biological systems, are resistant to change. And so our muscles and our nerves have evolved in a way that there are mechanisms to keep them from going haywire all of the time. In periodic paralysis, they go haywire for part of the time, but most of the time, the system is able to regulate itself and keep things in check. And it's only under certain stressful, or exposures to certain things like high or low potassium that one can precipitate a change, despite the fact that these people are living with the mutation all of the time. And I've shown that diagrammatically here, where the gene mutation confers this susceptibility to membrane excitability, but that an environmental stress of some sort is necessary then to push that individual over a threshold into an attack. And in the case of thyrotoxic hypo-KPP, we could add a third circle to this diagram where a third thing is required, and that is that the thyroid hormone levels are high. And for some reason that we don't understand well, high thyroid hormone levels in that disease work along with an environmental stimulus to push genetically susceptible people over a threshold into an attack of weakness. And so I've just diagrammed that here in a very simple way. It's the balance. It's like an orchestra or a ballet, a choreographed ballet, the way our cells work. It's really remarkable how the cells are regulating how sodium comes in, how potassium goes out, how chloride ions come in. And these have evolved in such a way and are regulated in such a way that most of the time things are in beautiful balance. And by opening a channel selectively, as we do when we fire a muscle, we're able to use this balance to initiate an action potential or initiate a muscle contraction or a firing of a neuron. And in the case of periodic paralysis, because of either too much sodium current leak or too little chloride or potassium ion conductance, any of these three ions, and then calcium, the calcium channel, the work that Steve talked about, contributes to extra sodium conductance. But by tipping the balance a little bit, the homeostatic mechanisms are still working. Biology is still working to maintain the balance in the muscle membranes most of the time. But under certain stressors or precipitating factors, patients can be tipped over some threshold where now they go into an attack of paralysis. That could last for a couple of hours or a couple of weeks. So it was partly because of the collection of a huge number of families by myself and my collaborators and my competitors that there were enough patients and with the new genetic knowledge that we could use to stratify patients being entered into a therapeutic trial that my colleague and collaborator Robbie Twill and Birch Griggs, who's the senior author on this paper, drove a study in which we participated that along with many centers around the country, to demonstrate for the first time in a double-blind controlled trial effectiveness of dichlorphenamide, which we now know as Keveyis, in treatment of the periodic paralyses. And in this paper, this first trial, which was published in 2000, there was also a huge amount of data from, I think, 128 patients who the group collectively treated in this trial. There's a huge amount of data, too, about the side effect profile, the side effects that patients had and so forth, and as well as the therapeutic benefit. And it was clearly beneficial. Now, the most expert people in the field who use these drugs at that time believed that they were effective medications for many patients, but we really, the onus is on us to prove that in carefully done controlled trials so that we can show that it wasn't, the bias of the neurologist who wanted the drug to work that it resulted in the positive finding. So this was a very important landmark that then led to a second trial and ultimately to the FDA approval of Keveyis only 25 years, still a long time, but pretty remarkable to think that in 1990 we had no understanding about the genes. We didn't know any genes that cause periodic paralysis. And then we began to clone the genes, and a clinical trial was done, and 25 years after the first gene was cloned, an FDA-approved drug is available and very beneficial to many patients. Now, it doesn't help everybody, and for the people it helps, it doesn't help them all the time. So it's a step in the right direction, but there's still lots of work to be done. And you've heard already this morning exciting data suggesting new possible ways of thinking about augmenting therapies and improving therapies for patients with periodic paralysis. Now, I've often said that my belief is that the main reason that carbonic anhydrase inhibitors don't work in patients is because the patients didn't get enough. And one of the reasons that patients don't get enough is that I think Dr. Weber mentioned that there are side effects from these drugs. They can cause some numbness and tingling. They can cause a funny taste on the tongue. And these side effects, in my experience, come on much more often when one raises the dose very quickly. And so back in the days when we didn't have Keveyis, but we had Diamox, I would start at very low levels and build it up very slowly because people aren't, periodic paralysis isn't life-threatening. I would discuss this with patients and say, hey, listen, this isn't going to help you for weeks or maybe even a couple of months, but if we do it really slowly, the chance of you tolerating the medication is going to be much higher. And if you tolerate the medication and it helps you, then that's what we really are working toward, right? So back in the days that I saw a lot more periodic paralysis patients, I started off very slowly, built up very slowly, and communicated that with the patients so they didn't expect a good result tomorrow or even next week. But doing that, I think, allows patients to tolerate the medications even better, and then by getting them up to the proper dose, you have the highest chance of getting the most maximal benefit from these drugs. So a lot has happened. We now know that, I guess I skimmed over that slide. Let me just go back briefly. So as we predicted in 1991 in that first paper describing the hyperkalemic periodic paralysis gene, these genes, or genes like the ones that we've cloned from skeletal muscle, are mutated in many different diseases. And this is not a complete list, but there are sodium channel mutations now that are known to cause familial epilepsies, familial long QT, cardiac arrhythmia syndrome. There are multiple potassium channels that cause periodic paralysis, or different ones that are expressed in neurons that when mutated can cause episodic ataxia, and others that cause epilepsy, and others that cause cardiac arrhythmia. And calcium channel gene mutations are now known to cause not only periodic paralysis, but episodic ataxia, epilepsy, and even familial hemiplegic migraine, as well as some congenital pain syndromes like chronic or insensitivity to pain or excessive pain, syndromes where patients have excessive peripheral pain to stimuli that would not otherwise be, or not normally be noxious. So the prediction turned out to be incredibly on the mark. These genes, relatives of the ones that we cloned from skeletal muscle, when mutated can cause many different phenotypes depending on what tissues the gene is expressed in. So some people have asked me, I have this, problem which sounds like a nerve problem in the brain. Could this be part of the periodic paralysis? in general, I would say probably not, because as far as we know, not a direct effect, because that gene is not expressed in the brain. However, I did make the point that Anderson-Tawil syndrome is different in as much as it's a widely expressed gene, unlike the other periodic paralysis genes. Sorry. So then I just want to come to the end. This is from a review from a section of a book that I edited a couple of years ago. And this was an introductory chapter that kind of framed the whole area of, biology and genetics of episodic diseases and my current thinking on the topic. We use the term primary channelopathies. We restrict this term to refer to disorders like the ones that we've been hearing about today, hypo-KPP, hyper-KPP, ATS, et cetera, where we know that there's a mutation in an ion channel gene, one of the genes that I've talked about. Now, we also know that there are acquired channelopathies where, and work from Vanda Lennon and Angela Vincent and the late John Newsom Davies, has characterized autoantibodies to different ion channels that can cause similar kinds of electrical and episodic disorders, but as the result of an autoimmune process rather than a genetic alteration in the ion channel itself. Now, I use the term secondary channelopathy to refer to genetic mutations in many other kinds of proteins that either regulate ion channels or interact with the ion channels or are responsible for the ion channels trafficking and localization in the cell. And then more recently, we've cloned a group of genes for a whole nother group of diseases called the paroxysmal dyskinesias. They're like the periodic paralyses in that they're multiple diseases, they're similar but they're different. And all of the genes that we've cloned in this group of diseases don't encode ion channels, but encode novel proteins that are novel proteins in the synaptic machinery. So the part of the neurons where neurotransmitters are released to give a signal jumping from one neuron to the next. And so as we learn more and more, some people make the mistake of calling anything bizarre and episodic a channelopathy, and I think that's not a good thing to do. I reserve the term channelopathy, primary channelopathy, for disorders where there is an ion channel which is mutated in a cardiac arrhythmia or in a periodic paralysis. And there are many other disorders that are also electrical and episodic that can result from different kinds of genetic mutations and different kinds of biological pathways. And we're learning more as we study other families with other interesting and important disorders. But I've gone into some of these other disorders to put periodic paralysis in a context. It's a pretty rare disease, but it's a part of a much bigger group of diseases. And it's true that we've learned a lot about epilepsy and migraine and peripheral pain from work that started in periodic paralyses. And it's true also that many of you have benefited in terms of treatment for myotonia, for example, from research that went to developing drugs for cardiac arrhythmias or epilepsy. So I think there's some benefit in thinking about periodic paralysis in the context of a bigger group of electrical and episodic neurologic diseases, because all of these have some similarities such that improvements in our understanding in one may contribute to better insights into another of the diseases from that list I began with. And then finally, I'd like to acknowledge my longtime collaborator, Ying-Wei Fu, who's been an equal partner in all of the work that I've talked about. Other collaborators like Andrew Charles at UCLA, Birch Griggs and Robbie Tawil, whom I've mentioned. And then finally, as patients with a disease, I encourage you guys to be advocates for your own disease. You're doing that already. But the funding that allowed much of the work that I've talked about was from the NIH, from your tax dollars. And the same is true for Dr. Cannon's work and many other people working in this field. So talking to your legislators and congressmen and women, and supporting increased funding for research is going to be necessary to continue to make these kinds of discoveries and advances in terms of understanding as well as treatment for all of these diseases. So you can also participate via your democratic involvement in the process and talking to your own representatives and letting them know that funding the NIH is really important, not only for your disease, which you care deeply about, but for lots of other diseases too. And I'll stop there and be happy to take any questions.
You mentioned autoantibodies.
Sorry.
Thank you so much. You mentioned autoantibodies to ion channels for the acquired form. Is there a screening test for that?
There is for some different diseases. That we're not aware of any autoantibodies to muscle channels that cause periodic paralysis, but in stiff person syndrome and in some of the myasthenic syndromes, there are autoantibodies to channels, the calcium channels in the presynaptic nerves, for example, that leads to some forms of myasthenia. And so in those diseases there is. It wouldn't surprise me if there were some autoimmune acquired channelopathies of skeletal muscle, but to date I'm not aware of any having been characterized by anyone.
Showed us picture with 3 channels where you listed the diseases below.
Yes.
Could you please show us again?
This one?
No, the 3 channels.
Oh, yes, this one.
This one, yes. I do have long QT. I do have periodic paralysis, but I do have also hemiplegic migraine. Do I have 2 mutations?
So certainly in Anderson-Tawil syndrome, we know that the KCNJ2 potassium channel is expressed in heart and in muscle and in brain.
But I have a mutation in SCN4A.
Yeah, so I don't think that causes hemiplegic migraine.
So I have 2 mutations.
Is your hemiplegic migraine familial?
Yes.
So that's quite possible. I can't say with any certainty without sequencing your genome, but that is, as I said, now the problem with negative data is that it doesn't prove anything. But when we do studies of, with probes to see where the SCN4A sodium channel is, we only ever see it, have only ever seen it in skeletal muscle. Now, does that mean it couldn't be in some small brain region that we didn't look at? No, not necessarily. But to our knowledge, there's no SCN4A sodium channel in the brain at all. And so seeing, I can't, it doesn't make sense to me that could cause a form of hemiplegic migraine. Now, sometimes, again, I don't remember the context, but there was a reference to an indirect effect. We know that things that happen in muscle and in our blood and serum and so forth can impact things in our brain too, even though the gene might not be expressed here. So whether there's some relationship there at a causal level, I can't say with certainty, but that's decidedly atypical. That
So I'm a zebra under the zebras. Yes.
What's that? You are a zebra, yes. Embrace it. And you can get one for for $500. I bet you could buy one from one of these guys.
Yes, I have a few years back I went through a family tree history, and I marked male, female, who had the paralysis, who had migraine, did the whole thing in color, and an observation was that a lot of the female did not appear to have episodes, but they appear to be a carrier of the gene that's passed.
Is this for which disorder?
Hypokinemic.
Hypo-KPP.
Yeah. And so
Yes,
they
so
appear to be, but
we-
even they showed no symptoms.
Yeah,
no.
we recognized this early on, as did everybody else who was studying hypo-KPP families. For some reason, women seem to be less severely, or in our experience, which is large, I don't think we had any, adult gene carriers who were male and who didn't have symptoms. But we had some percentage, I don't remember what it was, 5%, 10%, of women who had the gene mutation who didn't have any symptoms. So we don't understand why that is, but it's well recognized. That wasn't only our experience, but the experience of everybody studying genetics of these diseases around the world. So there's something about, and this is not uncommon, sometimes a disease that's genetic shows up and is worse in men than it is in women, and vice versa. And some are completely equal. But in this case, I don't understand what it is, but it may have something to do with progesterone and estrogen, hormonal effects of women that are different than men, that's protective, or maybe there's something about testosterone that makes hypo-KPP mutations manifest more severely. I don't understand what the reason for that is, but it's well recognized. That is clearly well recognized in that particular disorder, but not in hyper-KPP or not in paramyotonia congenita or not in ATS.
And second, can it be skip a generation and be passed down?
Well, it doesn't skip generations in the sense that a recessive gene mutation like cystic fibrosis can. But if you have a non-penetrant carrier, if you have a woman with the R1239H mutation in the calcium channel, which is I think the first one that we recognized, or R528H in the case of the most common one that Steve mentioned, there will be some percentage of women who don't have the symptoms, and so even if they're a gene carrier, it will skip a generation because if they pass it on to their children who develop symptoms, you'll say, but mom doesn't have symptoms. Well, she's a gene carrier, and for some reason, something like 10% of women with calcium channel mutations don't have hypo-KPP symptoms. We don't understand why, but that is the way it is.
Yikes. We have we'll try to do 3 more questions, and then we need a break.
Well, he's taking the microphone. Let me just come back to the question of, go ahead.
No, go ahead.
To different phenotypes. Now, we know that in episodic ataxia type 2, PQ calcium channel in the brain, that gene can cause hemiplegic migraine or episodic ataxia or spinocerebellar ataxia type 6. So, and then in the gene that we cloned for paroxysmal kinesiogenic dyskinesia, it causes this episodic movement disorder, and it can cause migraine, and it can also cause something else I'm forgetting now. But what symptoms you have depend on where the gene is expressed. If it's only in muscle, I only expect muscle symptoms. If it's in neurons, it depends on what kind of neurons it's in, and so there are examples where you get multiple phenotypes from the same gene mutation because the gene is expressed in different kinds of cells that are doing very different things.
You had mentioned that Anderson-Tawil syndrome is a widely expressed gene. Does that mean that it can affect the heart, muscle, and brain?
It does. So when Anderson reported one patient in 1971, that patient had cardiac arrhythmia, periodic paralysis, and developmental, the patient's eyes were too close together, the chin was too small. There were developmental features that were a little bit different than average, let's say. Now, Robbie Tawil and I have collected hundreds of these patients, and he's done a huge amount of clinical work, which is why he called it Anderson syndrome, and I added Tawil because Robbie has done so much beautiful work in this area. We recognized, well, once we cloned the gene, one of the first things we did is say, where is it expressed? Because if this is really the gene, it should be in the heart, it should be in muscle, and it should be in the cells that give rise to the distal limbs and the craniofacial structures. And it was. But it was also most highly expressed in the frontal lobes. And so that led us to bring 10 mutation carrier patients and their mutation negative siblings to UCSF to do extensive workup. And in a series of papers a former fellow Grace Yoon published, we really laid out the dysmorphic features of the phenotype, described a new dental phenotype that's common in ATS, as well as characterizing this neurocognitive phenotype, which is universal in the patients we studied. So it was cloning of the gene and then showing that it was in brain that led us to bring these patients into the hospital to study them further. And as it turned out, they do have a central nervous system phenotype. So we can, by understanding what the gene is and where it is, that can also lead us to look for and then find stuff that we missed before. You know, if you don't look for it, you won't find it.
Did I understand you right that you said people with hypokalemic periodic paralysis never have electrical myotonia with an EMG test?
Correct.
Okay.
In my experience, never. And I don't know if Steve or Dr. Weber would contradict me, but I say that emphatically at this point. I say, if you have myotonia, you do not have hypokalemic periodic paralysis. Now, one day someone might prove me wrong. There might be a zebra, an exception that proves the rule, but I feel that's my very strong impression, given quite a long experience over the years.
I might be that zebra. I have a mutation in the sodium channel, and I think I respond more to hypokalemic. That's how I fit better. I respond to potassium, and I know I've had at least one EMG test. I was actually done a long time ago by Dr. Tawil, that I did have electrical myotonia. So
let's talk about this offline, so I don't want to take up too much time, but I think what you have is, I mean, if you have a sodium channel mutation, that would fit with the myotonia, but then and some patients with sodium channel mutations and even with hyperkalemic periodic paralysis sometimes will have a low potassium when you draw it in the emergency room. So remember, it's not the serum level of potassium that we draw when you're in the hospital that defines the disease. It's what happens if we, give you carbohydrates and insulin versus what happens if we give you a large bolus of potassium.
We'll do one more and then we'll break.
Hi. I also wanted to comment on that. I am classic hypo, and there's 3 in my family, but I also have times that I don't know exactly what the trigger is for it, but I also have times where my hands will claw up really hard and tight, and it takes a long time for that to go away, and sometimes potassium will relieve that. But after a long time. So I do have that too, and I don't know which way. I haven't been genetically tested, but we can also talk about that later too, I guess. But when my hands will claw like that, I don't know which. I'm so classic, but what direction can I tell my doctor to look to see what test to? Is it that electrical test?
Well, an EMG and nerve conduction study are very helpful and important. To make the diagnosis of paramyotonia congenita, it should be done with before and after muscle cooling in a tub of cold water to see if there are quantitative, quantifiable changes in some of the things, the size of the response of a muscle in response to a small shock in the. So there's a whole number of tests. I think, our 2004 neurology paper, Miller et al., is a good starting place. Michael Hanna also and his group have published. I'm sure there are other papers in the literature, but our 2004 neurology paper is one that kind of goes through the diagnostic algorithm, decision points, what you need to ask or do, and then if yes, here, if no, there. And so that would be a good place to start, I think.
Okay, I understand it. Thank you very much.
Much, Dr. Ptacek.